Hello everybody, welcome to VitalCast. I'm Professor Mark Molloy, Lawrence Penn Chair of Bowel Cancer Research, the Colling Institute, the University of Sydney. I'm a research scientist, best known for my application of proteomic mass spectrometry in cancer, and I've recently moved to the University of Sydney to establish a new translational cancer research lab focused on bowel cancer and biomarkers. And this will allow me to broaden my research approaches to include genomics, metabolomics, in addition to proteomics, to investigate this disease which is newly diagnosed in 47 Australian men and women each day. I'm a Chief Investigator of the Sydney Vital Translational Cancer Research Centre since its inception in 2014, where I've collaborated with clinicians to undertake translational research in a range of malignancies. Focus of this episode of VitalCast, I want to give some thoughts around the concept of precision medicine and how I believe we should be using this well beyond the context of medical oncology. I'm going to talk about this in the context of bowel cancer prevention and treatment. One of the reasons for highlighting this topic is that I feel there needs to be somewhat of a rebalancing, as many have a description in their head that precision medicine equates to genome sequencing guided drug treatment. Well, the medical oncology community have best captured the intent of precision medicine in this way, but perhaps we should be thinking about this in a much broader way. In the setting of preventing colon cancer, colonoscopy is used to remove bowel polyps, which are mostly benign, but can, if left, transform into a malignant growth in some cases. The current clinical guidelines use risk factors based on family history and histopathological findings for determining the follow-up surveillance intervals. Such risk factors are an imperfect tool which fail to recognise the underlying genetic and epigenetically regulated gene expression programs that govern transformation and carcinogenesis of polyps. Let's consider this in the context of bowel polyps and clinical guidelines for follow-up. In general, small adenomatous polyps of less than 10 millimeters are associated with low risk of disease, and so follow-up is recommended after 5 years. But in the case of advanced adenomas of high grade, these are increasingly likely to become malignant, so follow-up should be much earlier, at 3 years. But what about a polyp of, say, 10 to 15 millimeters? The guidelines would suggest a 3-year follow-up, but just because it's slightly enlarged? Why not a 5-year follow-up? This would be far better for patients and save healthcare costs. So here I ask the question, is there a place for molecular analysis to refine and add granularity to such risk assessments? Molecularly defined risks fall within the framework of precision medicine, and given the decreasing costs of genomic analysis and the greater incorporation of this technique into modern medicine, it becomes highly likely that it will be unconscionable to ignore genetic features when defining risk in the near future. Now, notwithstanding, a limitation in deploying this approach in this context is our incomplete understanding of the transformative pathways of polyps that do transition into cancer against those which are histologically identical but remain in the pre-malignant state. This is an area that I'm eager to undertake new research. Another important area of precision medicine for colorectal cancer is whether we can diagnose lymph node metastases preoperatively. Given that radiologic imaging has modest accuracy, it is of interest to know whether we can use biopsies with molecular analysis techniques to provide a lymph node metastasis risk score, and this would be a precision medicine assessment. Preoperative definition of lymph node metastases could become of utmost importance, as clinical trials are now underway to assess whether neoadjuvant chemotherapy, that is, prior to surgery, in locally advanced stage 3 colon cancer is feasible and beneficial. Another case is a situation of bowel polyps which are removed endoscopically and return the surprise finding of a malignant foci. The conundrum here is whether these patients should undergo a major operation to remove a bowel section and the lymph nodes, as a conservative strategy, given that 10 to 20% of these patients actually do have stage 3 disease. Now, a molecular test of lymph node metastases potential would be ideal here, as the majority of patients don't benefit from additional surgery, but are exposed to significant morbidity and mortality risks. And finally, what of the gut microbiota and how analysis of metagenomes and microbiomes can influence clinical pathways? We know that low gut microbial diversity is linked with poor gut function, and that particular microbes are associated with adenoma and adenocarcinoma. For example, the presence of the oral bacterium Fusobacterium nucleatum in colorectal tumours, which is absent in the healthy gut and at lower levels in adenoma compared to malignant tumours, suggests utility for non-invasive diagnosis by profiling gut microbiomes. One exciting but yet to be demonstrated use of microbiota or microbiome signatures will be to inform outcomes of preventative, interventional studies that alter lifestyle risk factors and reduce the chance of a colorectal cancer diagnosis. Indeed, a precision medicine approach to prevention. So I hope I've convinced you that precision medicine concept can be used in numerous settings to inform clinical pathways. And I hope it gives you some insight into the directions that my new lab will be pursuing in our efforts to improve the outcomes for patients with bowel cancer or for those at high risk of developing bowel cancer. Stay tuned for the next episode of VitalCast coming up soon.